Okay, well, welcome back, and we're going to resume our session now. And I'm happy to introduce for this next session. It's going to focus on endo-hepatology, and there's no other group better to do that than start off with Ken Chang. And Ken is going to be talking to us remotely via Zoom because he's also going to be doing some of the live demonstrations afterwards. So Ken needs no introduction, from UC Irvine, really one of the pioneers in the field of interventional endoscopy and now also in third space endoscopy. So if we can switch over to UC Irvine via Zoom, and if Ken is there, we'll be able to start.
Tom, can you hear me?
Ken, I can hear you. I can hear you well. Oh, now I can see you, and I see your nice background there. Perfect.
All right, great. Let me share screen. It's been a great morning.
Yeah, we've had great cases so far, and it's yeah, John set the world record for a live course, so he will, that will be a record which will not be beaten.
I fully agree. That was very impressive. Okay, so Jason and I will tag team on endo-hepatology. I'll start with shear wave and liver biopsy, and then he'll continue with EUS portal pressure gradient measurement. These are my disclosures. So it's been a decade, Tom, since we kind of came up with this idea of endo-hepatology, a new paradigm in 2012, and broadly defined as the integration of endoscopy within the practice of hepatology, i.e., when scope meets liver. And back in 2012, we didn't have much in endo-hepatology. Basically, we had endoscopy to look for esophageal or gastric varices, portal hypertensive gastropathy, and then band ligation for varices. So there wasn't much, but the concept was emerging. And around that time, there were a lot of animal work and emerging clinical trials looking at especially EUS for looking at EUS, looking at ascites, looking at intervention, coiling, gluing, looking at the portal vein, assessing pressures, elastography. These are all emerging, but now 10 years later, we are pretty solid in many of these areas, and it's great to see because at the same time during these 10 years, we had another emerging pandemic, which was NAFLD and NASH. And what we've learned about NAFLD and NASH, it's becoming the #1 reason to need a liver transplant in the United States. And there are a few areas of unmet need that I think endo-hepatology can really help. One area of unmet need is to be able to definitively determine whether the patient has NASH versus NAFLD. And certainly there are some great non-invasive blood tests and imaging, but sometimes we really need a firm diagnosis. And I think that's where EUS liver biopsy may play an important role. So I will be talking about that. The other area of unmet need is whether in NASH or any liver disease, to be able to stage correctly where the patient is in the spectrum towards fibrosis, early cirrhosis, advanced cirrhosis, and on the way to decompensation. That whole slippery slope, we don't really have a great way of determining where they are, especially early on in the spectrum before they're clinically obvious, meaning before they have ascites, before they have varices. Can we see where the patient is and how they're moving along that spectrum? And that's where I think a combination of EUS shear wave and EUS PPG can help in a lot of these patients. And then finally, if the patient is unfortunate enough to develop HCC and there's a lesion, this is where on EUS, we can now employ contrast-enhanced EUS. So in the 20 minutes or so, I'm going to be talking about shear wave. I'm going to be talking about liver biopsy. I won't talk about contrast today. And then Jason will pick up with EUS PPG. So let's talk about shear wave elastography. The predecessor to shear wave is transient elastography. This is commonly known by the very high use of FibroScan. And essentially, FibroScan is vibration-controlled transient elastography. The probe generates a powerful shear wave. It's a sound wave that essentially can penetrate deep to the liver, about a 3 centimeter region of interest. And then the sound wave that comes back to the probe, the speed of that sound wave coming back is measured. And the faster the speed, the stiffer the liver, the slower the speed, the softer the liver. And so that's the basis behind FibroScan and transient elastography. In addition, the device can also look at fat content using something called controlled attenuation parameter, or CAP. And so it's great to have a non-invasive test that can both give you a sense of liver stiffness that then may predict fibrosis, as well as fat content, which then would predict steatosis. However, we've learned after thousands and thousands of cases that there are limitations to transient elastography. And the limitations include the fact that in obese patients, that pulse wave is attenuated by the thick adipose tissue, and we can have discordance in obese patients with transient elastography. Similarly, the presence of ascites can attenuate the values. There is no two-dimensional image guidance, so it's a blind procedure, and the pulse wave is going out, and it's assuming that you're hitting the liver and coming back, but it's not image guided. And the other limitation is it really can only be applied to the right lobe of the liver because of its nearness to the right rib area. The left lobe is not really measurable, and usually the spleen is also not measurable. So it can really only measure the stiffness of the right liver lobe, and there may be variability between right and left lobe, and that is also a limitation. There's been a number of papers now looking at some of this concept of discordance of transient elastography. And this recent paper looked at patients who underwent a liver biopsy and vibration-controlled transient elastography. And patients had both within a month of each other. And then they looked at concordance and discordance. So discordance was just defined in the study as on the transient elastography, it was F3, F4 fibrosis, but on the biopsy, it was either F0 or F1. So that's a discordance, right? Very high stiffness on transient, but minimal to no fibrosis on biopsy. The other discordance was in steatosis, and that was defined as moderate to severe steatosis on transient elastography, but mild to zero, less than 33% on the biopsy. Or the other way, meaning the transient elastography showed no steatosis, but on the biopsy, there was severe steatosis, greater than 66% on the biopsy. So we want to look at the discordance in fibrosis and discordance in steatosis. So what they found was 48.8%, or nearly half of the paired biopsies and transient elastography, there was discordance in either fibrosis or steatosis. There was a 72.5% fibrosis discrepancy, and there was a 32.5% steatosis discrepancy, quite high. So we want to break that down to see what were the predictors of discordance or discrepancy. And so this breaks it down. So first, let's look at BMI. So if the BMI was greater than 28, there was a 38.5% major fibrosis discrepancy. And most of this was overcall on transient elastography compared to biopsy. And there was a 32.7% steatosis discrepancy, and that could be either overcall or undercall. Then if you look at the patients with NASH, there was also a 44% discrepancy in fibrosis and 38% in steatosis. And if we look at severe steatosis, 53% major fibrosis discrepancy and 23% discrepancy in steatosis. So in the patients that we really need a really good scores, the obese patients with NAFLD and NASH, the discordance is high. So that is, of course, a concern in quite a few of our patients. So this study showed that all patients with advanced fibrosis or cirrhosis on liver biopsy were detected on transient elastography, so sensitivity was high. But for steatosis, the sensitivity was not so great, with less sensitivity in 19% of patients with moderate to severe steatosis were completely missed on transient elastography. And TE overestimated advanced fibrosis in over a third of the patient population. So the conclusion was that the TE was highly sensitive to liver fibrosis, but not as specific, and therefore liver biopsy remains the gold standard for accurate fibrosis assessment based on this study. So now we've talked about some limitations of TE. What is shear wave elastography? So shear wave elastography is a little bit different. As you can see from that little droplet hitting the water, think of that water droplet as the pulse wave. So the pulse wave, hits the liver, and then it sends this perpendicular wave, which is picked up by the linear array ultrasound. So unlike the TE, where it's looking at the wave coming back, with shear wave, it's looking at the propagation of the wave perpendicular, and it's picking that up on the imaging linear array ultrasound. So shear wave is used to assess liver stiffness, and it overcomes many of the limitations of TE. This push pulse generates a shear wave, which is propagated through the liver perpendicular to the ultrasound beam, and it quantifies the tissue stiffness by calculating the propagation velocity of the shear wave in the region of interest. And as we said, if the wave moves faster, that means a stiffer liver. If the wave moves slower, that means a softer tissue or softer liver. And now, since we can do this under EUS, the beauty of this is that we can look at shear wave of right lobe, but also left lobe, and also spleen. And it's looking like spleen shear wave has some advantages, because like we talked about in the liver, sometimes the pulse wave can be attenuated by fat, and sometimes it can be attenuated by fibrosis by inflammation. But in the spleen, there is no inflammation and there is no fat. And if the spleen stiffness is elevated, the only thing that really can do that is portal hypertension. So there's the secret sauce here that EUS can look at both lobes as well as the spleen. So let me demonstrate what that looks like. Well, hopefully our live case will also show it, but this is a nice 30-second video demonstrating what EUS shear wave elastography looks like. 11.4 is left lobe. Okay, those are good numbers. All right, so we have an E-value of 15.9 of the right lobe. The shear wave of the spleen is 55.3. So it was a very fast video, and we'll slow it down for the live case. But essentially, within a few minutes, we can assess both right lobe, left lobe, and spleen. And in this case, the spleen stiffness was very high. This was Alyssa Choi presented this as an oral presentation at this year's DDW. And so we looked at 44 patients, and Alyssa's on the call. Hi, Alyssa. We looked at 44 patients who underwent shear wave and liver biopsy in the same session. And we performed the univariate analysis. And what it showed us is that if we use a cutoff of 12.5 kilopascals on the EUS shear wave, that was associated in 81 to 88%, whether it's right lobe or left lobe, 81 to 88% of those patients had on biopsy F3, F4 fibrosis. So very, very high association with this 12.5 kilopascal cutoff. Then we combined both the shear wave of the left lobe, we increased it to 15 kilopascal, and we added the spleen shear wave of 26.3, and that had the highest operating characteristic for predicting fibrosis, greater than 3 on the Medivir score on liver biopsy, and that had a positive predictive value of 80% and a negative predictive value of 93.8%. So this is still evolving. We'll need a lot more confirming data across different centers, but it's certainly looking like EUS shear wave is going to play a role in assessing patients in terms of the degree of fibrosis and also predicting possible portal hypertension. So moving on now to liver biopsy, I just want to show you a quick video of the current technique for biopsying right lobe and left lobe. So here we're using the 19 gauge Francine tip. This is the single pass, single actuation. So the needle is thrust forward quickly. There's no suction when the needle is going forward. Then we pull the needle back and we make sure there's no flow in the needle tract. And you can see about a 5 to 6 centimeter from the right lobe. We go to the left lobe. We usually do bilobar and single pass, single actuation, another 5 to 6 centimeter. So we got 15 complete portal tracts from the right lobe, 15 complete portal tracts from the left lobe, a total of 30 complete portal tracts, which far exceeds the AASLD criteria of 11 complete portal tracts to be sufficient. And there have been a number of studies looking at comparison. This is David Deal's group looking at 110 EUS liver biopsy, 27 percutaneous, 38 transjugular. And EUS, because of its ability of doing bilobar biopsies, had a higher number of complete portal tracts in this study. There's also some suggestion that EUS-guided liver biopsy may be more cost-effective than percutaneous in patients with NAFLD. And a lot of the cost differential is factored in because the EUS liver biopsy can be done at the same time as your initial endoscopy looking for varices. And it also negates the need for screening EUS for looking for HCC. That can all be done in one. And so that could make this more cost effective. And now with the specialized core tip needles, we're getting better and better liver biopsies. This is a recent case, and this was a single pass, single actuation. And believe it or not, 8 centimeters of contiguous liver core, one specimen. And you can see that on the macro view, and here on the low power, this is the trichrome stain. This patient had cirrhosis, and despite cirrhosis, we were able to get a very nice intact core. If we zoom in on it, you can see that despite having macronodules and bridging fibrosis, here's quite a bit of fibrosis. You can look at the way that the liver edge is cut. It's very pristine and very sharp. So we're getting really, really high quality biopsies, and the patient is much more satisfied with EUS liver biopsy than percutaneous because they're sedated, and the recovery is a lot quicker. They go home right away when they wake up because we can watch for any potential bleeding under EUS directly. So a number of studies have looked at comparison of the Francine needle with the standard tip needle, showing superiority with the Francine needle. This study compared Francine needle and fork tip needle and showed the Francine needle was better. We also did a prospective randomized. So every patient had biopsy with both needles, and we showed again that the Francine needle with a single pass, single actuation had a better quality specimen than the fork tip needle, but clinically both are more than adequate. So this is kind of one example of comparison in the same patient, same lobe. And most recently, there's been looking at one pass single actuation or one pass 3 actuations, and 3 actuations got 24 complete portal tracks, whereas single actuation got 17, but either one is actually, beyond the AASLD criteria of 11. So I know that's a quick run through, but this one-stop shop, endoscopic liver evaluation is really catching on. At DDW, there were a number of talks on this, where with one procedure, we're looking for varices, we're looking for portal hypertensive gastropathy. We can do shear wave on that same procedure, right lobe, left lobe, and spleen. We can do contrast EUS if there's a focal lesion. We can perform liver biopsy. And now Jason's going to tell us on how we do EUS PPG. So Tom, thank you for your attention, and I'll end here.
Great, thanks, Ken. That was fantastic.